Then after doing that, you need to negotiate an agreement to assess. So you need to negotiate. So the family's stance, do not tell him anything. That is the family's thought, stance, situation. Now propose a compromise. Now you have to negotiate with the family, right? Gauge what they already knows. Now I'm not going to tell everything to the patient. I'm not going to bombard with all this information. You are having recurrence disease, everywhere the disease has gone, you are finished now, where multiple lung mets are there, multiple liver mets are there, you are going to die very soon. I'm not going to tell those things, right? I will, first what I will do is, I will estimate what he already knows and what he wants to know, right? So I will start the discussion like that, right? The clinician script, I completely respect your love for him. You have to tell that. You have to appreciate what these family members are thinking, because they don't want any harm to happen to the patient. That you have to respect that. So completely respect your love for him. Let's bring him in together with the family members. I promise I will not bluntly force any information on him. I'm not going to bombard all these things to him. I will simply ask how much he wants to know, how much he already knows, and how much he wants to know in advance today. And we will follow his lead. Today is not the only day I'm going to talk to him. Maybe the next session I will talk further, more information if patient can't tolerate today discussion further, right? So that is how you need to proceed. So you can ask the patient, how do you feel? If patient said very bad or not great, why is that? You need to ask why. What is the reason for that? Then he can tell, I have this cough, I have this back pain, and my body, I have lost a lot of weight, so I'm not in good shape. So you can ask, why do you think these things are happening? What is the reason for them? Do you have any idea? Then if patient thinks that this is due to the recurrence, he might tell, I think this may be due to my cancer, right? Then you can start from that. Why do you think this is due to your cancer? Because I know when cancer relapses, these symptoms are commonly happening, right? So then you can tell the patient, right? Yes, uh, that is the doubt we also had initially. That is why we have done the CT scan to see whether the disease has come back. Then patient might ask, what is the CT scan giving? What is the information giving to us? Is it has it come back? Right? So likewise, you can continue this dialogue, right? So to break the news, there are certain steps as the patient pays. There are certain steps. So the first, you must have heard about the spikes steps. The first one is setting up, right? So now this is actually part of communication skills, very important steps. So setting up the environment. So you need to bring the patient, you need to bring right. When we want to break the bad news or any news, especially the bad news in this situation, so what we need to do is there are various protocols that we can follow. The best one is the spike protocol. So there you need to set up. First thing is to setting up. So you need to bring the patient in and allow them to sit with the family and the best friend in this clinical situation, because that friend also, I mean, is a part of the family. In palliative care, the family is not only the blood relations, whoever act like family members. So it can be a friend, it can be a in-law, whoever. So they are take parting in helping the patient to take decision. So in this particular friend also part of his life, I mean, always in difficult times he is helping him. Therefore, he is also considered as part of the family. So we should allow him to come in. So in this type of communication, there are important things to follow. One is the environment has to be a very calm environment, and there should not be any disturbances. And one basic principle is, now from the clinical team side, suppose the clinician and a nursing officer participating for this, so two members. So always the other side, there should be more than two members. So from patient side, always the number should be more than the clinical team side. That is one basic principle, because that to ensure the family members that they are more powerful than the clinical side. Because otherwise, you can imagine when a patient or a family member in Sri Lankan settings, when uh, they go for a consultation, they are in a lot of fears. They don't have the liberty to communicate freely. So therefore they should feel like, I mean, they are the more uh, powerful, or they are the more powerful party in this communication. So they should give more power by allowing them to have more people, right? So in our experience, I mean, you must have seen when a patient comes, if there are two, three family members around them, sometimes I mean, in our clinical setup, we ask them to go out. That is bad, right? That is very bad. So when I am seeing a patient, I will ask whether there are anyone else outside wanted to come inside to participate in this discussion. That is very important. So that word itself gives them a lot of confidence, right? So those are small, small things we should develop in communication. So more participant from patient side, less from clinical side, right? And the other thing is, when you ask them to sit down, you should give, I mean, either the chairs should be equal size, or you should give the bigger chair to the patient, right? That is not happening in Sri Lanka, right? Never happened in Sri Lanka. So if the chairs are uneven, what I do, I will give the bigger chairs to the family members and the patient, and I will sit on the smallest chair, right? That is to break down the hierarchy, right? Because this hierarchy concept is actually downgrading the family members and the patient. So we should follow those rules in a good communication. So when we do these few things, patient and the family members build lot of confidence on the clinician. They build up a lot of trust on them, right? These things are not happening in this country, but we have to start these things. Now, patient is inside the clinical the discussion room. Family members are also by the side, and in this patient, the friend also sitting by the side. And so their number is four: mother, so the wife, daughter, and the friend and the patient. So number four. So our side, it should be less than four, right? So and no one is disturbing, no phones are ringing, there are no disturbing sounds. So everything is, now the setting up is okay. Now then the next step is perception. So you need to ask, what is your understanding? Now you need to start the conversation. So you are now, you have already got the permission, actually the okay from the family members. Now we are going to talk to the patient, right? So what is your understanding of why your breathing and back pain are worsening? What is the reason? What is your understanding? So then the patient will start to talk. So sometimes patient might tell already, doctor, I know that I have a cancer, and I know that it has come back. These people are trying to hide this to me, but I already knows these things. So mature at that level, right? So that is the best thing that can happen. Patient knows, family also knows, but family member doesn't know that patient knows the diagnosis, right? So then you can start from there. So next is you have to invite. If patient doesn't know the condition, so you need to invite. You need to ask, are you the kind? Now you need to differentiate. Now you are trying to invite the patient in a way that patient will ask if he want, right? So what you're asking is, are you the kind of person who prefers to know all the test details or just the next step? Now, if patient doesn't want to know what is in the CT scan report, then he want straight away jump to the treatment, right? So that means he already knows. Indirectly, what he's telling is he knows what is there, but he doesn't want to discuss. He doesn't want another person telling him that you have got a relapse. It's in your liver and both lungs. He doesn't want to hear it from another person. So we don't want to tell it because he doesn't want to hear it, right? So it is very important to know those things, right? So you want to see whether he wants to know all the details or whether he wants to jump to the next step, that is the treatment decision. So then if we say, yeah, I actually I want to know, then you need to give the knowledge. So give a warning shot. Knowledge is that we are going to give a bad news, right? So give a warning shot in small portions. So best thing is what you can tell is um, that reports, the contents in the report is not giving a good news to you, right? So if there are good news also, you can tell the reports gives both good news and bad news, right? So what are the things you need to know first, whether good or bad? So you can ask like that also, because always there can be good and bad news. No, now lung mets are there, liver mets are there, but there are no brain mets. So you can tell good news is there are no brain mets, right? So if patient says, tell me the good news first, you can tell apart from the lungs and liver, other places are free of tumor according to the CT scan. That's the good news. So then what's the bad news, doctor? The bad news is both, according to the CT, the lungs, both lungs and liver has the metastatic deposit. That disease has gone to both places. So that's the bad news. So patient has asked the bad news now. So you are telling it in small pieces. So I mean, after telling that disease has gone to the lung, patient may need to know how bad it is, whether they are large deposit, whether they are small deposit, various things they can ask. So small portion by portion, you have to give the knowledge to the patient. Then after knowing this, I mean, if you tell your unfortunately your disease has gone to the lung and liver, you don't start proceeding. I mean, you don't talk further. You have to wait and see what is the response from the patient side, right? You need to wait. So empathically, you need to allow space for silence, right? So I'm doing this thing in my patients. I wait and see what's the response. So by this time, you can see the emotional expressions from the patients. Tears might drop, patient might start to cry, right? So eye to eye contact might lose. So you will see the emotions are coming out. So you need to give some space, allow the patient to express their emotions, right? Crying is a emotion. So you need to accept that. So then you have to validate the overwhelming grief. So you need to estimate at a point, if the grief is going too much, I mean, you need to break it, right? So there are various ways that you can break the grief, emotions. You can give a tissue paper to the patient to wipe out the tears. So that is breaking the emotion. Small things, right? Other thing is, if it is appropriate, you can touch the patient. So when you touch, that flow, the emotional flow will stop. That flow will stop. So you should not stop it when it is inappropriate. If you want to see more emotions from the patient side, you will allow that patient to show the emotions. But if you think this is too much now, I should stop it. Either you can give a, you have to do it in an appropriate way. Now, if it's a female, young female, especially, so better not to touch the patient. So you can give a tissue paper to the patient, right? So you can see that patient and the family members, they will appreciate that. They will thank and get the paper. And then they will tell, okay, doctor, you can tell, you can proceed. So then you are getting the okay, you are getting the permission to go forward. And if the patient tells you, doctor, this is too much for me, I can't bear, shall we discuss this shall we discuss further in a later time? You need to appreciate that. You have to tell, okay, I'm going to stop it now for the time being. When you are okay, we will discuss further. So that is the way that you have to proceed. So empathically, if this is happening to me, how should I, what should I expect from the clinician? What am I expecting them to do? So that is the same way you should treat the patient, right? And after that, if you reach the acceptance, right, then you can jump to the strategy. Immediately, the most important thing is the plan for pain control and breathing support. So whatever the obvious symptoms are those, so you have to control those symptoms immediately without taking much time if patient goes into acceptance. Now, suppose if patient doesn't go on into acceptance, if patient is still at the early stage of getting information, so you can tell, okay, we will discuss later further details, but shall we control your problem, pain and other symptoms? Breathing difficulty is here a major problem, and pain is a major problem. So shall we control those things, and we will discuss other things another time, right? So then you can attempt to control the symptoms. So if you can manage to control the symptoms, patient will build up more confidence on you, and then the patient will invite you for further discussion, right? So that is the way you should proceed. So that is the spike method. It's a very helpful method that you can use in breaking bad news. And this is not only for bad news, and any treatment decisions, you can use this method, right? At least part of it. Okay, so after breaking the bad news, you offer multidisciplinary support to the patient and the family members. So immediate symptom management, you have to reassure both the family and the patient that immediate interventions will be begin. Otherwise, no point having all this discussion, wasting all this time if you are not giving relief to the patient from their suffering. So you have to give the confidence, and together relief for shortness of breath, dry cough, and severe back pain. So you have to target the relief. So shortness of breath and dry cough and back pain, all these things can be, you need to find out why this patient is having shortness of breath. If it is due to a effusion or any reversible thing in the lung, then you can reverse it. Otherwise, if it is purely due to the lung metastasis involvement, then you can start some opioids. Even for the back pain, you need to start opioids. With that, that will definitely relieve. Now, yesterday, um, I had a patient who had a relapsed colorectal cancer. So that patient was breathless, shortness of breath was there, and when the family members asking patient whether you have any problem, patient is telling no, but patient is breathless, and his facial expressions were very bad. So, but actually the breathlessness is due to two things. One is there was an infection in the chest. Other thing is multiple lung metastases. So, since there is a reversible cause, we are giving a trial of antibiotics to control the infection. It's a trial. We have given 3 days. I mean, our plan is to give it 3 days. If it is not responding, we will have a separate discussion with the family members whether we can, what will be the next step. But at the same time, with the antibiotics, I have given a subcut dose of morphine, and immediately within few minutes, patient became comfortable. So the daughter is also a doctor coming from Australia. She has told me that after giving the morphine dose, my father became comfortable immediately. I am really appreciating for that, because nobody has taken any interest in controlling that difficulty up to that time. So you can do miracles by by following these palliative care principles. So this is the physical component. The psychosocial care. So we can involve specialist palliative care team. We don't have in Sri Lanka, but whoever capable of giving that, and counselors and oncology social workers. So we don't have separate categories, because the social worker means those in developed world, the social worker is capable of identifying the patient's psychological issues, social issues, even spiritual problems, all these things, and they are capable of counseling the family and the patient. So they are capable of that. But unfortunately, our social workers, I don't know, they are having whether they have that capability, but at least they are helpful and they can do a lot of work. So the goal: help the family navigate anticipatory grief and maintain open communication at home. So up to now, patient and the family members has had a big barrier. They don't talk to each other regarding this disease at home up to now. But you will break this. You should break this barrier. Now you have already done that. Now the family members and the patient can talk to each other, communicate each other at home regarding their issues without any fear, right? So you have done that, and you have helped the patient to control their symptoms, mainly the physical. Now you need to explore the psychological issues, right? There may be hundreds of psychological issues they are having, so you need to explore them and try to resolve them. Now, modern paradigm of palliative care is not only the physical component. So, moving beyond the end of life to integrate biopsychosocial spiritual support is our main objective. So, you use clinical input, biopsychosocial input, and spiritual input. So, using all these, considering the patient as a whole, all these components, resolving family collusions is not just about medical ethics. I mean, not telling the truth to the patient is unethical. Because of that, we are doing no, not that. Resolving family collusion is lot of things. So it is about tearing down the walls of isolation so that true comfort, symptom management, and psychosocial resilience can begin. Now you can start managing and controlling the symptoms. You can start without breaking this barrier. You can't give the fullest support to the family as well as the patient, right? So you can understand. So this clinical situation, this is the first challenge that a clinician face when a family members and patient comes to your clinic most of the time. So I think we have learned how to manage these family collusions related to patient with life-limiting illness. Thank you. Thank you very much.